I didn't realize that was sort of his thing, because probably 15 years ago I was at a meeting somewhere and I was telling my assistant about George. I said, and it was so weird. I said, the guy next to him had his coat hanging off the back of his chair and he just filled his pockets with silverware. I thought that was a one-time event, but obviously not. So anyway, but George is a good friend, and yes, and she kept saying, Eddie's a good friend also. So thank you, Mr. President, for allowing me to be your speaker. When the invitation came, I asked, so what would you like me to speak on? And George said, HCA and health reform. I thought, okay, we'll narrow it down, That's pretty good. Easy to cover in the few minutes that we have. So I thought it's reasonable to ask about talking about a company, HCA, and then with health reform being on top of mind, at least for anybody in healthcare, it is something that we all probably should know a little bit more about. I'm sure George, in his wisdom of inviting me on this date, was the date where sequestration takes effect and healthcare is going to be impacted. It was perfect timing. That's why you asked me, right?
Check, please.
Yes. So anyway, I do find myself here today talking to this leadership group here in Nashville about a very important subject of health reform. I'm not going to necessarily talk about HCA, except that, as you mentioned, that we are the largest healthcare or hospital provider in the nation, and have 163 hospitals across this nation, as well as 6 hospitals in London, England, and that it's a great Nashville company. And if you've ever seen it, it's amazing. There's a Chamber of Commerce poster that shows the tree, the HCA family tree, and the roots start with HCA, and then over the past 40-something years, there are all these branches, and there are well over 300 companies that have come from people that have come through the HCA doors. So it's a small fraternity, but it is an important one to Nashville, not only economically, but I think ultimately we end up with great health care in this market, as well as great leadership. So I'm very proud to be with HCA. I will have been with them 31 years in July, and however, I'm retiring at the end of this month. And so people have asked me, what are you going to do? And so I said, I know for sure I'm going to take a break, and I'm going to have a little hiatus there. But I don't know, I've been contacted by a lot of people, and I think I've boiled it down to Dancing with the Stars. So that's what I'll be doing next. Well, to put this into any kind of parameters around time, I did want to narrow down and honor the request to talk about HCA and also talk about health reform. So I've really focused it on 3 areas that I'm going to look at today. And I'm going to talk about HCA, but HCA as a provider and how it's preparing for health reform. What you, as a business leader and employer, should know and how you should be preparing for this healthcare reform. And then, because the government-sponsored payment for healthcare is continuing to increase, and it's going to significantly increase with health reform, Obamacare, then I thought, well, what would it look like if that percent continued to increase, and why not just look at a country where it's gone to 100%? So I do have, since we do have experience in London, I thought I would share with you the health system, or the national health system in the UK, and share a little bit about what's going on over there. It's interesting when as far as the percentage of our GDP in the U.S. that the healthcare spend represents, it's around 18%. And you look at what is in the UK, it's just under 10%. So you start thinking about that, is that not everyone in the United States, maybe about 50 million people in the United States, do not have any care, any insurance, health insurance. But technically, anyone in the country of the United Kingdom has health care coverage, whether you're an illegal immigrant, whether you are a visitor or a citizen. you are covered by the national health insurance, and taxpayers pay for that. The percentage of the GDP there, you would think would be even higher than that, but it's, again, about 10%. Our concern, I would think, in America is that we continue, our percentage of the GDP continues to increase. In 1991, it was about 27%. Over the next 15 years, only went up just over 1%. Over the last 5 years, it's gone up 5 percentage points. So, and then in 16, it's estimated to be over 50%. So we're experiencing a move towards more and more government-sponsored health care. And you can decide whether that's good or not. There are a lot of pressures on healthcare providers. So again, I'm going to start with giving you some perspective of a healthcare provider, talk about how health reform is affecting us, and then I'm going to try to talk to you as a business owner and employer, which we are as well, and what pressures and how do we need to think about that. But there are many factors that are putting pressure on the healthcare providers today. The macroeconomics, just basically unemployment means less people have employer-sponsored health care, which is the number one, outside of government-sponsored, the number one method of getting health insurance is through your employer. In fact, health insurance through your employer was never intended to do that. It was just it was actually the school teachers union in Texas that came together and pulled together a thing that ultimately became Blue Cross of Texas, and they formed insurance. But today, insurance is expected to be offered to you through your employer. And in fact, it's viewed as part of your total compensation. And in fact, if you think about it, anybody that comes to work for you or you go to work for someone, you want to know what the insurance is and how much it's going to cost you out of pocket. So clearly, insurance today, from an employer standpoint, is becoming more and more competitive, more and more tough, because we as employers have absorbed a lot of the per employee cost of healthcare as a competitive thing, but those costs continue to rise. Everything, the pressure on all our businesses continue to increase. So it's tougher and tougher. And so the issue around macroeconomics is significant. Just competitive pressures on the commercial business, meaning those with commercial insurance. Over 100%, and we pay taxes, so we're called for-profit in HCA. Other hospitals that don't pay taxes are considered not-for-profit. But we all have to have more money coming in the door than going out the doors to do what we need to do. So we all are competing heavily for this commercial, what we call book of business, so to speak. But it's people with commercial insurance, because over 100% of the cost or the care is covered by commercial. So there's significant cost shifting from government payer, which pays less than cost, and a significant amount is cost shifted over to the commercial payers. So that's why our commercial insurance premiums are so high. That's why they go up at these unbelievable rates. That's why when you get your bill and you see a charge on it, that you go, there's no way an aspirin costs that much, and on and on. It's the whole pricing situation around the commercial insurance is just has kind of warped out of shape. Government reimbursements continue to go down. Medicare is either flat or decreasing. Medicaid, which Medicare is for the 65-year and older. Medicaid are those people that have a certain level of income, low income, and Medicaid cuts are drastic. States actually have to balance their budgets, so they're cutting huge amounts out of their biggest piece in most states of their state budget, which is the Medicaid budget. So we see Medicaid enrollees rolling off. We call it TennCare here in the state of Tennessee, but we see huge cuts there. And then just reform itself is a pressure. Why? There is so much lack of clarity around reform that we don't know, in many cases, as much research and consultants and others that help you try to think about it. You just don't know, and lack of clarity creates a lot of consternation in any industry. So while the need for reform is clear, the road to reform is very uncertain. We do need reform because there is, like I mentioned, a large number of uninsured, 50 million people in the United States. There needs to be a change in the way it's reimbursed. Today we get reimbursed as providers no matter what we do, right or wrong. We make a mistake, we get reimbursed. You don't need to continue that kind of scenario. You need to move towards outcomes and positive outcomes, and that's going to be part of this reform. There needs to be more transparency. You know, I'm asked sometimes, why do y'all charge $1? I said, we don't charge $1, we charge $2 for an aspirin. You know, it's amazing when you try to explain the pricing in the healthcare industry. If you charge, whatever you charge for a pill, there is so much other cost, including cost shifting, that you have to embed in that. So it's so confusing, very unclear, and quite frankly, it's upsetting when most people try to deal with it. People are going to deal with it more and more, so there is more and more price sensitivity to this. One thing that we know health reform will do is patients are going to be responsible for more of the bill, and therefore they're going to be more into price shopping. Because think about it, if you go to the hospital today, no matter whether you have insurance or not, and you show up to the emergency room, you get the same level of care. There is no difference. But if you had the ability to shop like you do anything else you do in your life, you would probably try to shop healthcare. Well, the price transparency is pretty low. That's going to increase, and you're going to have more you're going to have more of a insight into what pricing is for different providers. Tort reform or defensive medicine. You know, there are countries that actually limit damages, and the whole idea of you come in, you have a bad event, and you have a lawyer, you know, wanting to sue, then there are no limits set to that, and people, doctors, and other providers practice, quote, defensive medicine. If I don't do this extra test, I could get sued. That continues to run up. So tort reform has been on the docket for consideration. We have a very fragmented system. Think about this. What other system has this economic model? Those that seek the service don't necessarily pay for the service. Those that provide the service aren't paid by the people that they're providing the service to, and those that pay it don't receive the service or provide the service. It's a very awkward model, and so we're going to see more collaboration, not only with patients being more engaged, but also insurance and providers being more engaged. Lack of access to primary care. We're projecting to have an increase in the shortage of primary care physicians. More and more physicians are going into specialties for lots of reasons, but economically, a specialist can make more than a primary care physician, and a primary care physician goes to school just about the same amount of time, and with their reimbursement going down, we're seeing classes coming out of medical school with zero primary care selected. Zero. So what we're seeing is, you know, harder to find a primary care physician. That's going to be a concern, and so we've got to figure out ways of increasing access there. And as I said, the patients are going to be responsible not only more for the financial, but also for your own healthcare status. And therefore, you as an employer are going to be thinking about how do you treat people that smoke versus don't smoke in your benefits plans. So there's all sorts of things that reform is going to be involved in. So there are really two drivers to the health reform. One is the Affordable Care Act, which is called Obamacare loosely. It was enacted in December 24th in 2009. The Supreme Court upheld that law. It is the law of the land. It is happening. And the year 2014 is when it's supposed to kick in. So a lot of things around reform are coming out of that law. And that law, again, as I mentioned, is very confusing. You know, I think it was 2,800 pages. Most people, Nancy Pelosi, you know, said, absolutely, we have not read it. Just pass it, you know. So the other drivers of reform are just the market forces that I mentioned. So the objectives are to reduce the amount of people that are uninsured, reimburse for outcomes versus volumes, improve transparency, reduce cost and fragmentation, and increase patients' responsibility for their health care. So the provider implications are three things. I'm going to narrow it to three things. One is how are we paid? Two is how do we engage with patients and consumers? And three, how do we deliver care under reform? Well, how we're paid is going to vary by market with both the pace and the scope. But basically, as I said, we're going to be our performance is going to be tied more towards our performance. I mean, literally, you can do something, not intentionally, obviously, but something that's a bad outcome to a patient, and you get paid. It will change that you get paid on whether that healthcare outcome was meeting certain standards. So that is a huge change in the overall reimbursement for providers. Also, if you think about getting that long bill I mentioned, and you have an aspirin, you have this, and you have all this very long list of all the things that happen to you while you're in a hospital. Not happen to you, that sounded bad, but things that you receive while you're in the hospital. We get paid per line item, a la carte. That's going to change where not only are you looking at getting more and more reimbursement around a lump sum, here's what you get, take care of them like you're supposed to, and you have to meet certain quality standards. But now it's even expanding outside the hospital from the inpatient side to pre-hospital and post-hospital. So if you came in for a broken hip, had your hip replaced on an inpatient basis, went out to rehab, now there's talk of payments we call bundle payments that would cover both the inpatient and the rehab and some outpatient. So you become responsible for more along the continuum of care. That's something we're not accustomed to doing. We're not organized that way. We don't have experience in doing that as a general rule, and so therefore providers are having to gear up for that. As I mentioned, employer-sponsored health care is the number one way commercial insurance is provided. And now with this thing called the state healthcare exchanges, anybody not heard of that? State healthcare exchanges is something that is part of the Obamacare that each state could opt in and provide a state exchange or opt out and let the federal government provide a federal state exchange. And about half the states have opted in to provide the state exchanges, and about half have allowed the federal government or are allowing the federal government to provide that. The federal government's not necessarily geared up to provide all these. So all the infrastructure and all the organization is just going to be tremendous. Payers are going to continue to transfer risk to providers, and then payers are going to seek more narrow networks. Now, what a narrow network means, if you have a plan today through your employer, most likely you have access to any provider you want, and you have maybe 80% covered and 20% copay and deductibles and that sort of typical plan. But in order to lower cost of the insurance plan, you're going to see more and more insurance companies create what they call narrow networks, meaning we're not going to allow you to have access to everybody in the community. We're going to say you have a shorter list to select your doctor on, a shorter list of hospitals, but because we've gone and negotiated with those, they expect more volume. We've negotiated the discount, and we'll pass that on to you. These state exchanges are going to have to utilize more narrow networks, and so that's something that we will see differently. We as providers will not necessarily be in every insurance plan. It's going to cause a lot of disruption and confusion, and that's just part of what we're dealing with. So basically, what the impact of all this is going to be on us is we will see some volume shifting. We will see some declines in the growth of the Medicare payments, because they're going to say that's already happening, that we cannot continue to pay the increases that are actually being driven by the overall cost. Commercial rates are going to be affected because of the decline in employer-sponsored, and then just again the impact of year-over-year cuts will impact us. Well, how do we engage with patients? I'm kind of looking out there, about a lot of y'all are already half asleep, so I'm going to go on through this slide and you'll be fully asleep, because this is hard to follow. Is anybody in healthcare in here, by the way? Okay, what are you? Mission. Okay, all right. Yeah. So, for the most part, except for Wendy, I can say whatever I want to say and you don't know whether it's true or not. Even if I'm sort of in the zone, they're not going to know. So anyway, but in general, it's confusing to providers, and we have lots of consultants and lots of smart people that are trying to figure this out, and we still don't know a lot. Think about it for our patients. think about this idea of what do I do? What's this exchange? How does that work? How do I seek my employer just told me I'm no longer going to have insurance through them. What do I do? What's the price going to be? Who do I have access to? So just the pure lack of clarity is going to flow right to the employer, to the employee, to the patient, and we as providers are going to have to work to educate our patients and consumers. There's going to be significant price sensitivity. We already have feedback out there to say that people that are going to be in the exchanges are going to be very price sensitive, and they're willing to trade off price for access. In other words, I'll take a narrow network. I'll give up access to everybody if I can have a lower price. Now, by the way, who are the people that are going to be in these state exchanges? Like anything, it's about an 80-20 rule. We're going to see about 20% of the exchange population come from people that have current employer-sponsored health care, and they're going to move into an exchange. And then the other 80% are going to be people that currently don't have any insurance, the uninsured. And so they'll move into that. That's basically the estimation of what we're going to see. So we're going to see more people, more patients and their families seeking quality information. And if I get my knee replaced, like I did, then you're going to know how many did you do? What's your outcome? What's your patient satisfaction? What's your readmit rate? All these kinds of things. And consumers are going to demand greater access to their own records so they can move around in the system however they want to. So we as providers are going to work to build the awareness. We're going to have to create a much more longitudinal provider network. We're going to have to be more involved and work more collaboratively. One of the best things that we've found that helps patients is help them. We provide patient navigators, and so we're actually going to have to do more and more of that. And there are several other things that we have to do, including the whole medical record, the electronic medical record. Just for HCA, large company, it's $1 billion price tag on that, and it takes 5 to 7 years to roll it out. So it's a big deal. How do we deliver care? Again, greater coordination, and there's the things you can see on the screen. I realize what time it is, so I'm going to move quicker through here. But providers are going to have to work more collaboratively through forming integrated networks, mission point type organizations. And you'll hear lots of terminology in our world, what all that means. But ultimately, what you and the patient is going to have is access to a system that can coordinate your care through this maze of new provider affiliations. And we're going to have lots and lots of more data. I was in this room earlier this week for the Nashville Capital Network meeting, and one thing that I noticed is there's a lot of entrepreneurs in the startup phase of app business or the tech business or data business. So data, and more things are going to depend on you having access to the data and managing that data. So we're going to respond to the reform through our strategies and tactics. We have growth strategies. We have areas to improve outcomes, definitely investing in technology. We have customer relationship management tools that we use, network formation, and we're all across the country. Those vary from different markets, and then different payer strategies as well. So, market-based reform, what this slide says, we feel like we're in good shape. We've got a stable foundation, and we've got strong operating margins that allow us to absorb some of these cuts and still allow us to do the right thing and make the right investments. So what are the implications to you as an employer? Same drivers, same objectives. The employer implications are you pay or you play. You pay or play. How do you engage your employees? And then the question would be, how do you maximize your healthcare dollar? Well, everybody, as an employer, you're going to be looking at, do I pay or play? What do I do with my health insurance cost? If I don't provide it today, do I? If I do, should I not? And there are a lot of things that you have to consider. And clearly, one of the things that employers are doing today is looking at their health benefits design and looking at things like narrow networks and all sorts of strategies to reduce their healthcare spend. The employer penalty. This is a very confusing slide. and again, I'm going to go off the rule that I know and you don't, so I can say however I want to say. But I know some basic comments are, if you have 50 full-time employees or less, then you do not have to pay a penalty if you do not decide to provide insurance. But if you do, then it kicks into certain filters. One would be, do you offer essential coverage for every full-time employee? Full-time is defined as 30 hours a week or more. And if you don't provide these essential services, then you have to pay $2,000 annually for all your employees, even if only one of your employees doesn't receive essential benefits. So you have 100 employees, only one of your employees it falls out of that, you pay $2,000 times 100 employees. If you do meet that criteria, and you do, then the question is around your benefit coverage. Do you offer an insurance plan that would pay at least 60% of covered costs? If you don't, you pay $3,000 penalty annually each time an employee opts out and goes to a state exchange. And that's part of the way they're going to pay for exchanges. If you do provide that, then the question is, what's the affordability of that plan? And if that plan exceeds the cost of that employee coverage exceeds 9.5% of their household income, then you also have to pay the penalty. But if it doesn't, you don't pay a penalty. Now, can anybody give me that back? Can you recite that? You as an employer are faced with having to walk through this and decide, what are you going to do?
Make everybody part-time.
Well, actually, Ed, there are companies in this town that are out front looking at that option of saying, I'll make everybody 29 hours and less. And the problem with that is employers go, well, then I'm out of here. So you as an employer have an economic strategy around health care, but you just lost great employees because those people are going to be, your best employees are going to be attracted by somebody that says, hey, we're going to use health care insurance as a competitive differentiator for business. So, all right. With all that being said, if our country continues to move towards government-sponsored health care, what's it look like for a country that said, you know what, we're going to go all the way, we're going to provide 100%, and that was the UK. In fact, it was founded in 1948, post-World War II, and the founder, Nurin Bevan, Minister of Health, said, this is the biggest single experiment in social service that the world has ever undertaken. And it's absolutely right. It has grown to be the world's largest publicly funded health service. It's the fourth largest employer in the world with 1.7 million people. Its budget is just over 100 billion pounds, which is about $150 billion for over 63 million people. And I mentioned it covers you as a visitor, an illegal immigrant. Healthcare represents just under 10% of their GDP. The way their system works, and I bet most of you probably have heard of, if not even looked into, an HMO. An HMO is where they limit access. Well, that's basically what they have. It's a gatekeeper, called a primary care, called a GP. You can't do anything if you can't get past the gatekeeper. So you have to have a GP. Your GP covers you in your postcode, your zip code. You have no choice. It's who the doctor is in that area. And the only way you get to a hospital is through the emergency, or the GP recommends you to a specialist. And really, it's 100% covered. They don't really even have a way to charge you. There are a few copays and deductibles that they've added over time. But what the cartoon says in the middle, the patient in the next bed is highly infectious. Thank God for these curtains. There are wards. And so you think about America, you think about when you go to the hospital. In fact, I will tell you, as a hospital CEO, one of the biggest complaints I had, people coming to talk to me, was either about their bill, because of the transparency of, what are you charging me for all this, or just, I'm in a semi-private room, or my family is, I want out of there. Well, there, it's not semi-private, it's 4 or larger. And so you kind of wonder, where are we headed with that? We're all out there as hospitals building private rooms, and we're trying to move in the other direction. A lot of things said here. Number one, it takes a lot of money. It all comes from taxpayers for the most part. They are in deep trouble. They're having to cut 20 billion pounds by 2016. That's 20% of their budget. We are cutting 2% in sequestration, and we're all screaming. So I'm just telling you, The way that you control it is rationing care. That's the bottom line. So, long and the short of it is, to end up here really quick, is that there has been a private health care alternative created, and that's where we participate over there. You can buy private health insurance. It costs about £1,000 a year. We don't have emergency rooms. All that still comes through the NHS. It's a small portion of the overall of the UK population, but it's used particularly for big banks and big employers as a employee retention and recruitment tool. So what's the future of healthcare? Basically, I don't think we'll become UK, but we're moving more towards like that. So with that, questions? Sorry. Medicare supplement is, well, everybody gets the same kind of care in the same kind of place. There's no differentiation in the physical location, in say inpatient for a hospital. Over there, private health care is only covered in private pay units, a separate unit or a separate hospital. So it is physically separated from the NHS. That's the biggest difference, I would say. Yes, sir.
A huge part of what I do, I'm banking, is medical, probably 75–80%. And so I'm having to have a lot of these conversations. We're figuring in the cash flow. What are your plans going forward? And one thing, a couple of slides back where you were talking about the penalties, I think it mentioned one about the third down. You have to provide a plan that covers at least 60% of the cost. Mm-hmm. And you may have said this and I missed it. Providing a plan and what the employer is covering of the plan is two different things. Was there a minimum, how much they have to contribute to the plan? I missed that along.
I don't think there's a minimum on the employee.
Because you can offer a plan with the insurance company and not pay for it.
The minimum, I'm not sure of a minimum of the contribution by employees, but the minimum is 70%. It's called. There's 4 levels of plans, and I believe, and it's the bronze level. It's not the platinum. So there's a certain level of benefits, which then the patients will have to pick up a certain portion of the non-covered services, and that could be different by different employers, and. So, sorry for that short answer. Sorry I ran over. I was intended to be a little quicker, but George weighted me down with a bunch of nods.